Hi. So we start grand round presentation teaching on overdose. I will just go through the one case discussion, few basic overdose cases, and we just few sentences about paracetamol overdose audit we have done because of the recent unfortunate cases of overdose paracetamol in the hospital. So we can start from the basic things first. How can I do that? Okay, so a few years back, we had a case of 76-year-old lady who came to A&E, being referred by GP actually. So this lady had some alcohol dependency, and she has a history of overdose before. She has recently AF ablation. And as she told me that the reason why she took cocodamol to settle her chest pain and palpitation, she wasn't actually at all was going to commit suicide. And she took overdose of cocodamol to settle her chest pain. And early in the morning, 6 o'clock, and later she went to see GP because she didn't feel well, who has sent her urgently to A&E. So she, as you can see, timing-wise, she arrived 12:40 to ED, was given NAC around 2:30, which is around 7 hours later. So what's happened next? So this is a background, which is like, apart from being 76, relatively frail lady who walked only with a kind of Zimmer frame and in a wheelchair, was getting her regular shopping. So she was alcohol dependent, has a fatty liver disease, as I mentioned, recent AF ablation and diabetes. And her medications were several medications, but two of them are mentioned, rivaroxaban and bisoprolol, connected to her AF, isn't it? So when she came, due to codeine as well, she was a little bit drowsy, felt sick. Her heart rate was raised. She was in fast AF. And this is her first blood test been taken in A&E.
What's happening, Clive?
Sorry?
Sorry, are you moving the slides on, Victoria? I can't see the...
Anybody else can see? Oh, sorry.
It's stuck on the first one. Overdose in adults is all I can see.
Same here.
So
same too, can't see.
Okay, thank you very much for telling me that. So what to do then? I'm moving them, but what else? I'm sharing the slide. I'm moving. Maybe I'll redo it. Shall I redo it again? Yeah. So I'll do it again. I'll share the slide. Behave. Sorry, I closed it completely. Okay. Teaching. On my laptop. So open it again and I'll share it again in a second. There you go. You see that, can you? First. Can you see second one?
Yeah, I can see the second one.
Yes.
Okay, so I shouldn't open it completely. Maybe I just should. Okay, so as you can see, lady took overdose 76 and went actually to see GP rather than to A&E, and he was given NAC with 7 hours delay. These are risk factors for significant liver injury like alcohol, fatty liver disease, diabetes. As I mentioned before, she had recent AF ablation, and I suspect because she was still drinking alcohol, she went in a fast AF. So she's a relatively frail lady, but she was adamant to get to her shop in a wheelchair, and her medication was rivaroxaban and bisoprolol. So this is her vital signs when she came to ED, and the blood test, which showed some changes in her liver function, and high dose paracetamol 7 hours later. And obviously she was in AF. With the chest X-ray, possibly some congestion already ongoing. So any management was completely appropriate. They straight away started her neck and documented that. So fluids, because she was drowsy, they want to make sure there won't be any opioid side effects. She was on telemetry and sent to us. So I saw her the next day in the morning. The early morning when I just glanced in the wards on the beds, she was quite well and was having a wash and was very active and looks all right. But by the time I went through the ward and looking at her blood test, she was lying in the bed. It looks complaining of the epigastric pain, being sick, and she still was in a fast AF and oxygen 2 liters. So in a few hours later, literally, I saw her looking more unwell. We have repeated blood tests straight away, and you could see on the next slide that her blood tests were rapidly deteriorating. So if you can see that this is the blood test she came with. So it was creatinine, this blood 88, and bilirubin slightly raised, alkaline phosphatase, ALT. That is her level. INR was all right at that time, but that's the following blood test we have done the next day in the afternoon. And you can see that INR shot up to above 10. ALT was going up, and renal function getting worse, and she had abnormal amylase. Later we find out that with paracetamol overdose you can develop pancreatitis. So she has developed a few renal failure, worsening liver function, and pancreatitis and coagulopathy. By the afternoon, we repeated blood test. Obviously, with all these numbers, we proceeded a few more tests. I just mentioned that lactate was 3.6. RCT abdomen showed pancreatitis, and we've done ultrasound scan simultaneously with the discussion with the King's renal unit about further management, ITU review as well. So ITU, there were several ITU consultants seen her because of such a rapid deterioration. I think a night consultant as well, ITU seen her, and everybody were categorically saying that she's not for further escalation due to her comorbidities and risk factors. There was conversation with the liver transplant. You have to always do that with any side effects from the overdose, but particularly in her situation. And in majority cases, liver unit is very helpful, but they always rely on the ITU support, because these people, if they are going to have any transplant, they should be supported by ITU. Unfortunately, this lady was literally deteriorating in front of you. We had some troubles to contact her family, partially because she was living very isolated from the family, from her children. I think we just found some far relative who managed to contact everybody, and the same day family arrived and we brought them bad news. We did ask palliative team to see this lady. She did tell that she doesn't want to die. She didn't want to die, and she didn't realize what she was doing. Was very sad to see what's going on in front of you. And actually, this is a realistic evidence in front of you of humble paracetamol action. But this is what happened. She died a few days later. So I will talk to you about overdose. It's not going to be kind of big discoveries. Anybody, all right? Discovery. So it's going to be basic management of a very common overdose medication. Partially this come on with a few cases in the hospital when we had some frail elderly people were prescribed paracetamol and they unfortunately develop liver injury, and they died. So that is one of the reasons why this presentation is here now. So we're talking about in general overdose. It's a relatively common presentation in emergency department. I have done few numbers of general overdose in Wales and England, and you can see in 2016 we had 3,700 cases of death. Paracetamol had about 200, but it's more common presentation of paracetamol overdose from the all overdose, but I would say more successful outcome rather than people who has opioid dependency when they have a higher rate of death. So basics are basics. We're going through the overdose, and just always remember you have to be a little bit of detective here. Very important to know when, how much, what's else been taken, why, but important then to get as much history from anywhere you can, paramedics, friends, relatives, anybody. If somebody brought patient to ED and was about to leave, you have to hold this person and get as much information as you can to see what exactly happening, what's been taken, and in all details. So the next assessment would be ABC. Always remember a Glasgow Coma Scale level, glucose level, and obviously general assessments. I find this quite beautiful eyes. So assessment's going to be you're generally assessing people, looking for evidence of IVDU, any needle marks, pinhole pupils is very common in opioid overdose. Because are they dry, are they sweaty, are they tremulous, is there any other smell of alcohol? So general assessment to see what are common overdose medication side effects you can recognize, and they're consistent with your story, what exactly been taken, is a presentation actually reflects that. So altogether, I just found this rather beautiful eyes of people who definitely not delirious as far as I know. But it's just one of the symptoms of opioid overdose. You have pinpoint pupils, red eyes. You can think about other, cocaine, crack, bends, antidepressants. You have other kind of evidence of overdose, and dilated pupils with amphetamines, opioids, etc. So that it's not real one because it's rather healthy looking eyes, although. So now the management wise, you need to get medication, reduce absorption or elimination. So the basics are basics. It's a word like ABC, gastric lavage. I don't think it's commonly used because of the risk of aspiration, and needs to be some certain airway protection. But activated charcoal should be used if overdose been within 1 hour or something has prolonged absorption time. And elimination, for example, this example always give aspirin as a drug should be treated with elimination. So alkaline diuresis, for example. Right, let's get on with the overdose. Yes, overdose antagonist. So yeah, we'll go through some of them. So naloxone we'll mention about opioids overdose and acetylcysteine with paracetamol. So paracetamol, very common. As I said, although the death rate is lower than opioids overdose, but presentation is more common with paracetamol overdose. And I suspect people, as I said, our example of ladies, they feel that paracetamol is relatively humble and won't cause much problems. I've done it before, I'll do it again, and it shouldn't be any kind of, I'll come to the hospital, they'll treat me and I'll be fine. I'll get support from mental health team. But sometimes these things can get worse, especially if people have certain risk factors. So about paracetamol metabolism, just basics thing. So when paracetamol's in your body, metabolize in the toxic form, acetyl P-aminophenol. That form, when it's conjugated with the glutathione, which is mostly contains in the liver, became non-toxic metabolite. This is an idea, but unfortunately, liver potentially losing glutathione with more and more paracetamol coming in, and when this the depletion, when the number of glutathione depleted, obviously toxic form of paracetamol increases, and it's combined with hepatic cells and irreversibly can destroy them. This is a simple explanation. So the necrotic liver. Right. What's going on with the liver? Is a healthy liver. We're talking about liver which potentially can recover with paracetamol overdose, or how the damage is happening. So in the first 24 hours, people relatively feeling well, maybe a little bit of sickness, but generally they're feeling all right. In the next several days, where the liver start gradually damaged. So the people developing some pain, and they developing, I don't know, jaundice, maybe a little bit of confusion. So developing evidence of hepatotoxicity. So day 3, 4 is kind of day when this rapid liver failure starts. And this point, people normally will go to ITU, some support, organ support unit, to ideally be prepared for liver transplant, transfer to London King's for liver transplant, that approximately situation. As well, people continue some support, organ support, and there would be phase 4, which can start from day 4, 5, in the next few weeks, phase of recovery. So so we have the situation, if it's would be some level of recovery for the liver, all these people will proceed to the liver transplant. Obviously, when we have people with this situation, we do need to clarify exactly how much they took paracetamol, calculate ideally, calculate how many milligrams per kilogram they took. Obviously, if they're within few hours, you can give a Chacal, and we'll check in paracetamol level after 4 hours, and ensure that treatment was started as soon as possible. So you can be guided by this line. You'll be guided by the history. If you don't have paracetamol level, you have to be guided by the history, how much paracetamol has been taken, what is the risk for the hepatic toxicity. So if it's under 4 hours and the risk and story is very convincing, you can start treatment straight away. You can wait 4 hours paracetamol, and obviously there would be with target overdose. There's a low threshold to start an acetylcysteine with these people. Now, is the most important. We can talk later about risk factors people, and it used to be in the past a second line in this graph about malnourished people or people who are having chronic liver disease, for example. These people have a low level of glutathione or depleted level, with that substance that can combine toxic paracetamol. So these people, the reason why they're high risk, because they don't have enough storage of glutathione, and they're at risk of hepatic toxicity development earlier. So the management of paracetamol as the same ABC, details about story, how much, when, how much been taken, and obviously you need to look at the weight, any risk factors, malnourishment, or any history of liver problems, and try to get NAC first 8 hours actually. Right, this is we on any ED we do have this available, and you can print out from the website online anywhere. This is a prescription of N-acetylcysteine. Well, I won't go through the numbers. It's well known to everybody. What is a NAC? What N-acetylcysteine? What is it? Kind of why we're using that? What it does, it provides enough provides sulfhydryl, the substance for glutathiones to synthesize even more. So basically, it supports further synthesis of glutathione, which will protect liver from paracetamol toxicity. So, well, they say it's not benefit after 15 hours, but we do tend to do 21 hours of N-acetylcysteine infusion, which is accepted by all the organizations. There's another Scottish NAC infusion kind of the proforma, which is for 12 hours, but it's not accepted by, I think, not accepted by BNF or kind of majority of institutions. So because of the lack of evidence or risk of consequences of paracetamol overdose. So we stick to 21 hours. So yeah, I mean, we based our follow-up with the paracetamol overdose. We check in repeating blood tests, paracetamol level, and we check in several blood test parameters, including liver, renal function, lactate, and coagulation, and as well BM. Never forget glucose level. Now, this is a people with a risk of developing, as I mentioned before, people develop risk of developing liver toxicity. People who have a liver disease with depleted storage of glutathione, people who had staggered overdose, which is sometimes in majority cases not very clear how much they took, and that is difficult to establish. The safest would be just start N-acetylcysteine, start treatment, provide all support, and make sure the plan monitoring, blood test, etc., being provided. So that is just provide basics, King's criteria for liver transplant. And on the first column, these are addressed to the paracetamol, purely paracetamol. So criteria is not only kind of we're guided by the liver function test, but actually criteria is different. It's acidosis, level of lactate, pH, encephalopathy, coagulopathy, and renal function. I mean, that is very helpful, especially for the liver unit. But from our point of view, I think any deterioration, paracetamol overdose, any further deterioration, evidence of any acidosis, renal failure, liver failure, confusion, encephalopathy, you don't wait for those numbers come up for the required one. You have to warn and escalate these cases earlier to speak to King's and speak to ITU, so if people have a clear plan what's going on, because things can go, as I said, with case with Our Lady, she deteriorated literally in a matter of hours, not even days. So being well in the morning and going kind of using highs go in the afternoon, it's literally people getting sick quickly. So escalate one ITU, one liver unit at King's College. So they have some idea and they have a list who to expect or who is getting worse in Hastings Concourse Hospital. So this is a that's basic about paracetamol overdose. As I said, I'm not telling you anything new. You know, it's everything. It's just something to remind you rather. And I will mention audit we've done, just few pages about it. So we just go quickly through the opioid overdose. As I said, it's more common, can be even in elderly. We have quite a few elderly people who actively using opioids. Doing It's Hastings. Okay, so we need to recognize opioid or overdose toxicity. You get in your history. You know this gentleman has some drug dependency. You have a needle marks on the arm, and this friend potentially saying that he has some drugs. So what you're looking for, you're looking for evidence of opioid overdose, which most common is confusion, respiratory depression, and one of them, if you can't get proper history, but you see pinpoint pupils with all the history, you can suspect opioid toxicity. Opioid acts through the Mu receptors, but we don't go to the more physiology. So management ABCD as usual. Don't forget glucose. So naloxone. It's a kind of more even trial drug. Naloxone, I would say, it's so common in certain areas of high dependency population. So that some of them have a special kit. I think Brighton has provided people with certain small dose of naloxone for the emergency help to avoid fatal death. Ambulance as well can go with a trial of naloxone if they have evidence of opioid toxicity. Some very small dose of naloxone are the test, very appropriate. And then it depends how people improving or not improving, they're getting worse. You have to consider, obviously you're getting ITU involved and escalating case to ITU and make sure they're coming. Don't forget to clear document when you give naloxone, because we have had a case when opioid overdose person who was dropping GCS, but every time ITU registrar was called, the person was given naloxone. So by the time ITU reg would become, GCS was normal. And then he would have a look and leave, and patient will go drowsy again later on. So that would be clear documentation when naloxone was given, how much, and consider infusion, obviously with ITU involvement. Okay, so I think BNF has a clear, very good protocol for that. Next one, aspirin. I won't take you a long time, so we're almost finished. So aspirin has two acid balance problems. So first of all, people developing respiratory alkalosis, basically because of the stimulation of respiratory center. So people overbreathe, hyperventilating, respiratory alkalosis. That consequently involve kidney compensation mechanism, and people developing metabolic acidosis, which is more fatal. So I suspect if somebody with aspirin overdose and you do blood gases when they're coming in and they have evidence of hyperventilation, respiratory alkalosis, these people has to be highlighted and make sure they will have a repeated blood gases later on. So the mechanism, when they develop in metabolic alkalosis, the general metabolism changes by carb, lipids, protein, and they start developing ketones, lactate, and other metabolic acids. So that is a serious complication. That is the reason why these people having more kind of complicated management next step. How they present? They have certain GI symptoms. They have tinnitus and vertigo, mainly because of the maybe hyperventilation and CNS changes. So they're sweaty, they have palpitation, hyperventilation. Then there would be CNS involvement with the confusion, seizures, etc., and other complications, including hematemesis, coagulopathy, and renal failure. So in this situation, to be aware, so you identify this gentleman or lady had a respiratory alkalosis and potentially developing acidosis. So these people has to be escalated, get fluids, give antiemetics, just to monitor and have a certain plan when we're repeating levels, repeating blood tests, renal function, and repeating BBG. So management again, A, B, C, D. So the treatment for aspirin, it's obviously you give charcoal if been indigested in the last few hours, or we need to do elimination. As you can understand that aspirin eliminates through the kidney, and one of the treatment would be aim to increase urinary pH by the given in IV sodium bicarb. That is one of the mechanism. Obviously, given IV bicarb and being unwell, etc. So ideally, these people has to be on HTU, not being heroic on the wards. And next step would be hemodialysis. So on HTU environment, regular blood gases, people, the anesthetist or HTU team can identify early indication for hemodialysis. Okay. And the last one, the least, tricyclic antidepressant overdose. They are as well quite common presentation in emergency department. Most of them are mostly symptoms support, but sometimes you have cases when you can't clarify what medication you're taking, and people do develop typical symptoms of tricyclic antidepressant overdose. So we can divide them into two groups. So anticholinergic effect. So basically they have dry symptoms. They have a dilated pupils, beautiful dilated pupils. They can't see with them. They have a urinary retention, have palpitation and even fever. And evidence of confusion and CNS involvement, including seizures and respiratory depression. And from the cardiac toxicity, or we called quinidine effect, we can variety of heart block, brady, tachy, and QT prolongation. So these people has to be on cardiac telemetry. So one of the assessments for overdose, don't forget, it's ECG, and we're assessing QT interval. Okay, so management very much is similar. ABCD, and these people can get worse, so we cannot address situations they need any, if the GCS is low, they need intubation, fluids, or diazepam for seizures. And the same, basically we're addressing the symptoms of tricyclic overdose in this situation if yeah, I don't think that there's a risk of vomiting. These people high, but if you have evidence of indigestion within an hour, I don't think they would be so unwell in the first hour. But anyway, they can benefit from charcoal and address symptoms, consider bicarb. But as I said, I don't think you should be heroic on ED or medical wards. These people has to be highlighted to ITU earlier. Because overdose in general, they can make people relatively fast, it's quickly sick. We do have a lot of cases, and it's quite relaxing and sometimes less attention paid to these people, but they do need always need clear especially at the beginning, to make sure that everything's been looked at, that we haven't missed anything. We know dose, time, what else been taken, when, how. We have all history. We know this is what been taken, the initial blood test, ECG, VBG. It's been very reassuring. So yes, you can a little bit relax, and you know that you can repeat blood test at some point interval. But if things are anyway from the history, whatever been taken, initial assessment, blood test, ECG, anything abnormal, you have to put a red flag on that and make sure this could be follow-up or reviewed even several hours later, just not to miss anything, okay? That's it. If anybody wants, and you have any questions, please come up. But I'll open the paracetamol.
Victoria, I don't have any questions. I do have a couple of comments to make.
Yes.
The first relates to the use of gastric lavage. The main reason why that's no longer used is that there are several reasonably good studies that show actually gastric lavage promotes absorption of drugs by the volume load forcing them into the small bowel. And that's the main reason why gastric lavage is no longer indicated in the management of overdoses, not because it's unpleasant or associated with specific side effects. The second point to bear in mind is that I think everybody always needs to look at tox base, and that's what we're in the habit of doing for every overdose, because things change almost on a daily basis. For instance, the last amendment to the paracetamol guidance was made in December of last year, so things do change quickly. And with regard to paracetamol, because we do see obviously quite a lot of it in our department, I think the two key points to bear in mind are that N-acetyl cysteine, if given within 8 hours, is almost 100% effective, which is why ToxBase says if presents within 8 hours or you get the level back within 8 hours, hold off for the paracetamol levels. Conversely, after 8 hours, if they've ingested a potentially toxic amount, namely 150 milligrams per kilogram, you should start it immediately in all patients, pending results of the blood test. And the final bits relates to staggered overdoses of paracetamol. There was a change, a significant change to the guidance about 2 years ago. And the conventional teaching was that all staggered overdoses, that paracetamol levels can't be interpreted, so they all need a full Parvalex regimen. That's no longer the case. And tox-based guidance is that you start Parvalex immediately. And if the 4-hour paracetamol, then you do bloods 4 hours after the last known ingestion. And if the paracetamol level is below the treatment line, the INR is normal, the ALT is normal, creatinine is normal, and the patient is asymptomatic, you can discontinue it, and the patient is medically fit. So that is quite a big change. And I know some of our juniors still get that wrong, and they're referring every patient with a staggered overdose for admission, even though that doesn't, they don't actually need admission for that. So anyway, take-home message really is look at tox-base from our perspective, because it's up to date and it changes.
Yeah, thank you very much. Thank you, Paul. So brilliant comments. So I just have a look at them. Just show you audit. It's very important. As I said, there's a few cases where in a hospital when unfortunately a few elderly people died by the prescription of intravenous paracetamol, which was toxic for them. So just look at the guidelines, just repeat guidelines again and again. It's only about intravenous paracetamol in this situation. Look at the indication. This is only for pain and fever, if it's indicated. And the most important thing, you look in the weight. So weight before you prescribe any paracetamol, especially intravenous. You check the weight, ask for the weight, or look at the patient, if they're above or below 50 kilos. Because as you can see, below 50 kilos, if you have a look at the 60 milligram per kg maximum, so if patient is 50 kilos, they only indicate to have at least a maximum 3 gram per day, but obviously there could be less than that, so even less paracetamol should be given. The same for people with the risk factors for hepatotoxicity. For intravenous paracetamol, people who is above 50 kilos, they as well should have maximum less than 3 grams per day. So again, if somebody asking you to prescribe paracetamol, obviously look indication. If they really need IV and paracetamol, are they really in pain and need fever and need IV paracetamol? You check their weight and you check any risk factors or history of hepatic pathology. And I'll go through the results. So we had people, 25% out of 220 were on IV paracetamol. And so it's in general 55 people in 1 day snapshot were on IV paracetamol, and compliance were only 45 out of 55. So 10 people, which is 18% from the general people who were on paracetamol, on IV paracetamol, had prescribed an appropriate dose of IV paracetamol, potentially being at risk of developing liver injuries and toxicity. So that is a message. So that is a big number. It's a 1 day snapshot. Nobody kind of picked up the notes. Look at the 220 notes. 55 been on IV paracetamol, and 10 people were prescribed higher dose. So that, keep in mind, do not come. It's a humble drug. You think you knew, you've done it many times, you prescribed, but next time when you prescribe in paracetamol, please just stop and think, weight and any history of liver pathology, irrespective of whatever somebody asking you, and indications. Does it really need to be intravenously? Just remember, it's an indication is a mild to moderate pain and fevers. So that is the message. And thank you very much for coming and listening. And thank you very much, Paul. Any questions?
May I just ask for
Yeah.
oral paracetamol? The guidelines, are they still under 50 kilos, 1 gram 4 times a day, or is it 500 milligrams 4 times a day? Should that also be reduced orally?
Orally as well. It just the guidelines, particular IV, is high toxicity intravenous paracetamol. It has a high toxicity. I wouldn't prescribe paracetamol high dose either for the oral, and guidelines more clear about intravenous paracetamol. But people with a liver failure or malnourished people should have a 500 half dose, 500 ppb. Any pharmacist will tell you that.
Yeah.
You just say it's not 55. Because normally people carry on the paracetamol as it should be forever. So it's better to keep half dose.
Thank you.
Yeah. Okay.
Victoria, thank you very much for the elaborative talk. Do you have any role for bicarb in tricyclic antidepressant? And also, how common is that beta blocker overdose in your experience?
Sorry.
Is there any role of bicarb in tricyclic antidepressant?
I have mentioned that bicarbs, advised to give bicarb, but I would say I wouldn't leave it along without escalating to the.
And how common is a beta blocker overdose in your experience?
I think it's more overdose. It's very rare, but we quite frequently having bradycardias or kind of complete hard block on background having second bisoprolol, but it's very rare. So normally you would have a bradycardia develop second heart block.
Mhm.
Yeah, thank you.
And if we have to use the glucagon, how frequently? Because the half-life with the glucagon is very short. Does it need any infusion or repeated dose?
I think you can try glucagon, but I think the first thing people would be on the CCU on Saturn pacing. You would play with glucagon. It's just only to save time while a consultant or cardiologist will come or will transfer to Eastbourne, for example, for pacing. But the glucagon is such a huge amount. By the time you get it together and etc., people are getting quite unstable. It's hard getting them well enough to
Yeah. Thank you. Thank you very much.
All right. Shall we finish that?
Yes. Thank you. Thank you. Thank you.
Bye.